This program is presented by University of California Television. Like what you learn? Visit our website or follow us on Facebook and Twitter to keep up with the latest UCTV programs. Also, make sure to check out and subscribe to our YouTube original channel, UCTV Prime, available only on YouTube.
The topic that we're going to be discussing next is delayed graft function or ischemia-reperfusion injury. This has been really one of the most difficult entity to, in fact, reverse. And over the past, 20 years or so, or 25 years, there have been several attempts with drugs and agents to minimize or decrease delayed graft function, yet the incidence of delayed graft function remains quite high. However, we have now better understanding of the mechanism of action that leads to ischemia injury, that basically leads to the clinical entity of delayed graft function. And for the first time, we have a couple of really interesting molecules that are being tested to prevent the injury of ischemia-reperfusion injury. And so the first speaker is Dr. Ryo Hiroshi will discuss the pathogenesis of ischemia-reperfusion injury that leads to delayed graft function.
So I'd like to set this talk up as a very basic overview and form some structure around the notion that renal ischemia-reperfusion injury is a very complex entity. And I could show you at least 30 slides with lots of arrows and lots of mediators, cells all over the place, and confuse the crowd and probably put you to sleep very quickly. But I wanted to give more of a structure to the notion that renal ischemic injury is an inflammatory disease. And now we're elucidating a lot of the mechanisms that are involved to the point where we can really think about targeting the areas that we think are important. Similar to immune function and immune recognition, however, I truly believe that there is not going to be a single magic bullet in the end. There won't be a single drug because of the redundancy in the inflammatory mediators, cytokines, cells, molecules, etc., that are all involved in ischemic injury. Now, this is a problem that confounds all of us, surgeons, medicine folks alike. We see renal ischemic injury in many clinical settings. In patients in shock, those who have undergone traumatic injury, those with sepsis and systemic inflammatory response syndromes. We cause the ischemia many times as surgeons during cardiac surgery, during cardiopulmonary bypass. Vascular surgeons clamp the aorta, repair pararenal or visceral aneurysms. Even clamping the vein of a kidney is harmful. We've shown in our laboratory that venous clamping can be as harmful or sometimes even more so than clamping the artery of a kidney. And of course, we in kidney transplantation cause surgical ischemia by definition, by cutting off the blood supply, yanking a kidney from either a live person or a deceased person, and then putting it on ice or a machine, and then letting it sit there for a while before reperfusing it in the form of a transplant. In the form of severe ischemic injury, we have delayed graft function, which obviously has actually gone up in incidence in the last 10, 20 years for multiple reasons. And interestingly enough, even mild acute kidney injury in any of our hospitalized patients is associated with significant increased mortality. So it's an ongoing problem, a problem that is increasing in incidence and its effects. So delayed graft function in kidney transplant has certainly been increasing in incidence over the past decade. And this increase has been contemporaneous to an increase in the utility and using ECD and DCD kidneys. As our donor population ages, age is one of the main risk factors of delayed graft function. And in the past, it was associated with worse long-term graft survival. This has been come into question now in more recent studies. And the question of is DGF in the absence of rejection associated with poorer outcome, the jury is out. There are now conflicting data, but it is clear that DGF does in fact increase graft immunogenicity and may set you up for acute rejection as well. Now, the elucidation of the pathophysiology of renal ischemia-reperfusion injury has led to the development of several strategies, including strategies related to donor management, how we do organ procurement, organ preservation solutions, recipient management, and use of pharmacologic agents in both donors and recipients. The main point of the pathophysiology of ischemic reperfusion injury is that it's a very complex interplay, and the cells and the molecules and signaling pathways involved include the leukocytes. And both the innate immune response and, it turns out, probably the adaptive immune response are both important in the pathophysiology of ischemic reperfusion injury, probably in different phases. The interaction of those leukocytes with endothelial cells is another essential component to the pathophysiology. And then, of course, there's the damaged cells themselves, the renal parenchymal cells, of which the renal medulla is the most sensitive because, like in other situations, it's the farthest from the blood supply. It involves inflammatory mediators, cytokines and chemokines, oxygen-free radicals, and the notion that there is cell death going on. And there's a mixture of both what we would think of as classic apoptosis and necrosis going on. And it turns out in the cell death literature, we always thought that necrosis is sort of a passive or accidental mode of cell death. But nowadays we are actually considering that necrosis is also an active and regulated and programmed set of events, and we'll get back to that. So again, ischemic acute kidney injury is clearly an inflammatory disease. The inflammatory response leads to multiple things, including endothelial cell activation, enhanced endothelial cell leukocyte adhesion because of upregulation of multiple adhesion molecules. For example, the selectin family, the integrin family, and Ig superfamily, all three of which are upregulated when endothelial cells are activated due to ischemia. This in turn leads to leukocyte entrapment and ultimately, even after reperfusion and the ischemic hit is over, a compromise in microvascular flow. This is a schematic of some of the things that occur upon ischemia and then reperfusion. Leukocytes first start to roll along the endothelial cells due to selectin-mediated rolling, and then firm adhesion due to Ig and interactions with the Ig superfamily and integrins. And then there's leukocyte extravasation, and then reactive oxygen species are generated, which leads to tissue injury. There are many pro-inflammatory and immunomodulatory cytokines involved, and these are all potential targets for therapy, obviously. It has been well elucidated that certain cytokines are very important in the damage that we see in ischemia-reperfusion injury, namely IL-1 and IL-6, as well as TNF-alpha, TGF-beta, and MCP, and other chemokines that attract white cells into the area. When you interfere with any of these, one tends to ameliorate ischemic reperfusion injury in the preclinical models. It turns out that TLR4 and toll-like receptors also play an essential role, and one gets protection from renal ischemia reperfusion injury by inactivating TLR4 and performing renal ischemia reperfusion injury in TLR4 knockout mice. Serum IL-6 levels actually indicate a higher risk of death in patients with acute kidney injury. And other mediators such as nitric oxygen and nitric oxygen signal transduction can either be beneficial or exacerbate ischemia reperfusion injury. When one performs ischemia, actually there are many protective molecules that are upregulated and elaborated. Those include things like heat shock proteins and hemoxygenase 1. Hemoxygenase 1 is actually responsible for the production of carbon monoxide, and I think Dr. Fang will go into some of the clinical trials that have been performed with carbon monoxide, but suffice it to say that carbon monoxide has multiple effects, and I'll get to some of them, which may protect against ischemia reperfusion. Other molecules that are upregulated during renal ischemia, VEGF, erythropoietin, also shown to be protective against renal ischemia, nitric oxide, and some prostanoids. Now, one of the hallmarks of renal ischemia reperfusion injury is the influx of inflammatory cells in a very stereotypical order. At the beginning, you see neutrophils pretty much go in. At later stages, one sees macrophages, different subtypes of T cells, and NK cells as well as NKT cells. All of these cells are homing to the interstitial space, but the earliest population that we see are neutrophils. A lot of the assays that we use to look at the severity of ischemia-reperfusion injury include the assays, for example, for myeloperoxidase, which can be a marker for neutrophils. Now, are these the actual cells that are causing the damage? What's the clinical significance of the neutrophilic infiltrate? Well, when you block neutrophil activation, it certainly partially protects animals in some AKI models. But depletion of macrophages does the same thing, and so does depleting the T cells. Nude mice without T cells, and in some models, RAG1 knockout mice, which don't have either T cells or B cells, they tolerate ischemic reperfusion injury better than completely immunocompetent mice. And in fact, selective reconstitution with CD4 T cells worsens renal ischemic reperfusion injury. Again, like in a lot of different T cell models, it turns out that T cells that elaborate gamma interferon may be worse than those that elaborate IL-4. NKT cells and NK cells are also found in these infiltrates. NKT cells are those T cells that actually express both the markers of T cells and NK cells. They express a canonical T cell receptor that recognizes glycolipids presented by CD1, which is a class 1-like molecule, and they produce a variety of cytokines in response to both antigen recognition and ischemia reperfusion. So what happens during the reperfusion phase? Well, you rewarm, you reoxygenate, and there are multiple reactive oxygen species that are generated after reperfusion and with the supply of new oxygen. Superoxide anions and hydrogen peroxide form, which then form hydroxyl radicals, and this causes lipid peroxidation. Now, there are endogenous scavengers of these reactive oxygen species, but they are often overwhelmed during an ischemic reperfusion hit. And some of the strategies have been to either add oxygen scavengers, radical scavengers, or to increase the endogenous ones that are present. But the end result is that clearly ischemia affects both the structure and function of the tubular epithelial cells and causes what we thought of as pretty much epithelial cell necrosis. It turns out that both apoptosis and necrosis occur, and even after the ischemic hit is resolved, in other words, you restore blood supply, there's ongoing interstitial inflammation and interstitial microvasculopathy that's characterized by the swelling of endothelial cells, endothelial cell dysfunction, microvascular occlusion, and therefore can cause ongoing renal hypoperfusion even after the cause of the ischemia has been corrected. Now, what has been going on in the field of cell death? Well, we classically thought of there's two different kinds of cell death. Apoptosis, which has been seen in certain models of acute kidney injury, and necrosis. There's a third form of cell death, which is called autophagy, where cells generate energy and metabolites by literally digesting themselves. They digest their own organelles and macromolecules when a starving cell is deprived of growth factors, and it does this in order to survive. Now, these three different modes of cell death can be distinguished by morphologic, biochemical, and molecular attributes. And this is a schematic of the three different types of cell death. It's thought that apoptosis definitely is an active process. It is a characteristic cascade that is dependent upon caspase activation. And caspases are proteolytic enzymes that cleave their substrates or autocleave their substrates, such that the program for cell death occurs and DNA fragmentation occurs, and it is a relatively clean form of death. Whereas what was known or thought of as necrosis, again, sort of thought to be an accidental byproduct of just not having enough blood flow, occurs in literally cell membrane rupture, and basically the cell just explodes. And those were the two main forms of cell death that were really being thought of as occurring in renal ischemia-reperfusion injury. Now, there's a newly described sort of program necrosis that is being described, which is called necroptosis. Now, this actually involves death receptor-mediated death. In other words, a death receptor such as TNF receptor, ligands such as TRAIL, fast ligand on FAS, resulting in cell death, looking like necrosis, is caspase independent, but is very dependent on the activity of certain cytokines. And in fact, there's a program that occurs to result in cell death that is apoptosis, not p53 dependent, not not caspase dependent, but it is a newly described form of cell death which is probably occurring, maybe to a greater degree than apoptosis, in renal ischemia. So again, apoptosis, as we classically think about it, is defined by cell shrinkage, chromatin condensation, membrane blending, nuclear fragmentation, and proteolytic activity of the caspases. And there are two pathways that lead classically to this caspase-dependent cell death. There's a death receptor pathway, which is known as the extrinsic pathway, and it's activated by TNF family members binding to their ligands or receptors, the ligands binding to their receptors, initiating the complex of this death-inducing signal complex, and the main caspase that's activated in the death receptor pathway for apoptosis is caspase 8. The mitochondrial pathway, which is an intrinsic pathway depending on caspase 9, involves intracellular reactive oxygen species, DNA damage, and is often p53 dependent as well. And p53 is known as a guardian of the genome, so if you get DNA damage from gamma radiation, whatever, you go on to die instead of form cancer or some other mutant cell. And obviously that p53 activation can initiate apoptosis as well. So what determines whether you go into apoptosis or not? Well, it's an interplay between pro-apoptotic and anti-apoptotic members of certain gene family members, including BCL2. This is what's actually happening. Both pathways are being activated in ischemia-reperfusion injury. A schematic of the two different pathways, classical pathways to apoptosis. So you can get a classic death receptor being activated by ligands such as TNF, eventually ending up in caspase 3 activation, or the mitochondrial or intrinsic pathway also ultimately resulting in caspase 3 activity. Again, the ultimate goal or endpoint is apoptosis. Now, what determines which death pathways are actually being activated? It depends on the stage of the cell cycle, the type and magnitude of the apoptotic stimulus, the stage of activation, and those relative levels of pro-apoptotic and anti-apoptotic molecules. Now, is that what's going on? Yes, that happens, but so does another form of cell death. Again, necrosis was previously considered fairly accidental, not programmed, and it is clearly initially thought to be a primary mode of cell death in ischemia-reperfusion injury. When one saw apoptosis going on as well, people thought, oh, it must be apoptosis, not necrosis. Now it's going back to a notion that it's this other thing called necroptosis, and I'll get to some of the evidence of that. Now, in ischemia-reperfusion injury, there's no question that plasma membrane channels and extracellular fluid influx into renal cells, and you see progressive swelling of the actual cells, the organelles, leakage of proteasomes and lysosomal enzymes, proteases, and eventually plasma membrane rupture. But it's interesting, in some instances, they may be initiated or modulated by the same death receptors that actually lead to apoptosis. So what is the role of this necroptosis? A recent, actually about 10 years ago, it was described in immune cells that there is a caspase-independent mechanism by which FAS, TNF, and others can lead to cell death. In a very recent study in KI, the notion that ischemic reperfusion injury is mostly due to necroptosis as opposed to apoptosis was supported by the experiment when you treated these mice with necrostatin. This is a very highly specific RIP1 inhibitor, and RIP1 is the key kinase involved in this necroptosis pathway. It reduced organ damage and renal failure even if administered after reperfusion. Now that's pretty unique. Most agents you have to have on board before you get your ischemic hit. This agent worked even after you started reperfusion, which makes it much more clinically viable if you think about it. You know, a lot of the things that we think about, trauma, et cetera, we can't actually administer the agent before the ischemic hit. Of course, you can think about doing it in the transplant setting in terms of treating the donor, but this is an interesting agent that works even after reperfusion. A pan-caspase inhibitor in the same model did not actually prevent organ damage. And so the thought was that it actually is not a caspase dependent apoptosis that's dominating in this model, but rather this RIP1 dependent caspase independent pathway. And just a schematic that when you stimulate the death receptor complex, you can either go down the classic caspase dependent apoptotic pathway, or if that's inhibited, you can go down the RIP dependent necroptosis pathway. Again, we have to think about what agents we want to use, because we probably want to use different forms of agents that inhibit both. So the prevention of the actual cell death that goes on after ischemia-reperfusion injury is obviously challenging, because there are different forms of cell death. And reactive oxygen species, or calcium ion overload, or protease activation can all lead to death from multiple stimuli. Now, I don't have time to go over every single agent that's ever been shown to ameliorate renal ischemia-reperfusion injury, because there are literally over 200 to 300 agents, if you look up in literature, from one mechanism or another that have been shown to ameliorate renal ischemia-reperfusion injury. If you look and try to characterize what those agents are and how they work, you can sort of group them in certain ways. Some of them simply upregulate or substitute for things that are protective against inflammatory molecules. Others try to upregulate protective molecules. Others try to reduce pro-inflammatory cytokines or reduce their effects, and others inhibit endothelial activation or inhibit the leukocyte endothelial interactions. So roughly, those are the categories of agents that have been tried. Interestingly, some of the first agents that were done were agents that reduce oxygen-free radicals or antagonize them, and HO1 is a molecule that does get upregulated during ischemia, but if you upregulate HO1 expression, it clearly protects. And interestingly, HO1, again, is the enzyme that produces endogenous carbon monoxide. So your body's producing carbon monoxide all the time when you have heme breakdown, but if you give exogenous carbon monoxide in certain preclinical models, it clearly protects against ischemia-reperfusion injury. I think Dr. Fang may be mentioning some of those. Finally, some other agents that may actually be helpful. Caspase inhibitors have been tried, and again, an Nexin 5 dimer might be is in progress, and actually Dr. Vincenti is leading an investigation into Nexin 5 dimers. So, as you can see, looking at the mechanisms can direct you to think about which arm of the inflammatory cascade and the cell death pathway you may want to try to interfere with to ameliorate this problem. What about other strategies? Well, it turns out, again, as I mentioned, the adaptive immune response may be quite important in the actual cellular damage that occurs. And in fact, several attempts, including agents such as FTY720, which direct cells away from antigen centers, even thymoglobulin, co-stimulation blockade in animal models have been shown to ameliorate ischemia-reperfusion. What about the notion that Steve said about delaying CNIs in terms of treating our patients with delayed graft function? Intuitively, you would think that CNIs cause renal vasoconstriction, are inherently nephrotoxic, or something that is good to avoid during that acute DGF period. In fact, there's no really good evidence, although Steve mentioned in our small series there might be some, but there's no clear evidence that immediate CNIs perpetuates DGF or impairs recovery significantly. And actually, cyclosporin can inhibit apoptosis by blocking mitochondrial permeability. And in fact, in an acute MI trial, decreased infarction size when administered before cath. So what do we do currently to prevent or ameliorate ischemia-reperfusion? Well, we have donor management goals, and we can talk about what in the donor we may be able to fix in terms of before going to the operating room with a deceased donor. We use cold preservation fluid. We use either University of Wisconsin solution, which has free oxygen radical scavengers, or histidine tryptophan ketoglutarate. Some of us in the transplant world use pulsatile cold perfusion. There's a question of whether warm perfusion itself is actually a better way to go. In fact, there's a trial with hearts right now ongoing with a transmedic device, literally is a heart pumping in a box, where they perfuse the heart with human blood, actually donor blood, and keep the heart pumping while it's being transported to the transplant center. So that's an ongoing trial right now. It's a transmedic trial. I won't go into other clinical trials because Dr. Fang will describe these. And on the horizon, what are other treatments that may help us? Well, it turns out that certain stem cells, mesenchymal stem cells, and maybe even just their supernatants, are beneficial in many ischemia-reperfusion models. So that bone marrow-derived MSCs or injection of adipose-derived mesenchymal stem cells are both found to be protective in renal ischemia-reperfusion injury, and even infusing endothelial progenitor cells that are expressing protective forms of eNOS may also be protective. So in summary, many questions remain. When is a cell irreversibly committed to death? When is it too late to save that cell? What criteria drive the selection of which cell death pathway that a cell commits to? How can you really prevent ischemia-reperfusion injury? Is it due to inhibition of apoptosis? Is it inhibition of necroptosis? Is it both? We've participated in a couple randomized controlled trials. Actually, we have one ongoing to see what the best way to manage our deceased donors are. Is it pulsatile perfusion, cold perfusion, warm perfusion? Should we think about mostly recipient-directed therapies in terms of inhibiting their leukocyte activation or inhibiting leukocyte endothelial interactions as we have for several decades? How should we manage our patients with established DGF? So in general, again, the strategies have included reducing the production of harmful molecules, decreasing the inflammatory response, inhibiting cell death, or decreasing microvascular changes. It's extremely complex interplay with all these different cells, molecules, second messengers, mediators, and we've gotten significant progress understanding the interplay of all these things. But it still remains a major problem. We've gone a long way in terms of figuring out what some of the mechanisms are. We have a long way to go. It's going to continue to be a major cause of increased mortality and morbidity in the hospital. And in fact, DGF is on the rise. So the need is there. We need to be perhaps more thoughtful, more inventive, and really think about all the arms that we need to knock out before we really get on top of renal ischemia-reperfusion injury. Thank you.